Hello and welcome to the Spinal Cord Injury Forum. My name is Jeannie Hoffman and I'm the clinical psychologist and the director of the Northwest Regional Spinal Cord Injury System here at the Department of Rehabilitation Medicine at the University of Washington. Tonight we are so pleased to welcome Dr. Fatma Inanici. She's a postdoctoral researcher at the Restorative Technologies Lab here at the University of Washington, and she's going to be sharing information about recent studies on transcutaneous electrical stimulation and how we use it to restore motor function. So, Dr. Inanici, I turn it over to you. Thanks so much for joining us.
Okay, thank you. Welcome, everybody. I would like to thank the SCI Forum for inviting me to speak tonight. And thank you, Jeannie, for the introduction. I will start with the outline of my presentation. Today, I will talk about electrical spinal cord stimulation as a developing treatment tool after spinal cord injury. Specifically, I will talk about transcutaneous spinal cord stimulation, which is a non-invasive form of electrical stimulation. I will introduce the studies we are conducting in our lab, and I will present our results. Finally, I will summarize what we learned up to now, what we need to know further, and the potential future of this new treatment. Let's look at the treatment of spinal cord injury. Rehabilitation is the most commonly used treatment to enhance function and independence, as we all know. Traditional rehabilitation approaches are mainly concentrated on compensation for the loss, modifications, and adaptations, rather than restoration of the function. However, newly developing techniques are quite promising to restore function after spinal cord injury. These new approaches are guided by the principle of neuroplasticity and neuromodulation. So let's remember what's neuroplasticity. Neuroplasticity is how we adapt to changing conditions, learn new facts, and develop new skills. During the 20th century, it was widely believed that after maturation is completed, nervous system becomes a hardwired structure with fixed neuronal networks. But since then, this dogma has been overturned by a huge body of research, which shows not only the nervous system can change, but it changes continuously throughout life. In response to everything we do, every experience we have, such as training or even response to injury. Understanding neuroplasticity opened new windows for developing restorative therapies for many neurological disorders, including spinal cord injury. Now we know that spinal cord is smart and it has remarkable neuroplastic properties. Additionally, we learned that some parts of the spinal cord, which are called central pattern generators, have automaticity for certain movements in the absence of voluntary control. Such spinal circuitries can effectively control postural motor tasks and to some degree, basic rhythm and timing of stepping and independent standing. All these evidence triggered the research studies that focus on the uninjured spinal circuitry below the injury level to promote functional recovery. So task-specific rehabilitation therapies were developed for activation of spinal cord pathways, such as intensive weight-bearing locomotor training on treadmill. Besides automaticity of certain circuitries, even more impressive observation was that these circuitries can be used to generate voluntary control motor tasks if they are adequately neuromodulated to a critical level of excitability even after complete spinal cord lesions. Neuromodulation refers to alteration or modulation of nerve activity using electricity or chemical agents. By targeting specific nerves, neuromodulation strategies suppress or stimulate nerve activity to achieve the desired effect. Combination of restorative therapies are also under consideration. The rationale for the combinatory treatments is that each therapy independently may not be sufficient to reverse the paralysis, but when combined, they may have synergistic or additive effects to enhance the outcomes. Let's look at the electrical stimulation as a neuromodulation tool. First of all, I would like to clarify that there are two different types of electrical stimulation approaches among restorative therapies. One of them is functional electrical stimulation, which is also known as FES. Functional electrical stimulation activates muscles through the stimulation of the intact peripheral motor nerves. Activation of the muscles in certain sequences promote functional movements. But one of the major limitations of FES is that stimulated muscles tend to fatigue very quickly. It's because fast switch muscle fibers are activated by FES. This is opposite to the physiological recruitment order, and these fast twitch muscle fibers are more prone to fatigue. The other stimulation approach is electrical spinal cord stimulation. There is growing evidence that electrical spinal cord stimulation can modulate neural circuitries and can restore motor function after injury in both animal and human subjects, animal models and human subjects. There are different methods to electrically stimulate the spinal cord. These are epidural stimulation and transcutaneous stimulation. Epidural stimulation requires surgery. Stimulation electrodes and the battery are implanted in the body in this technique. Transcutaneous stimulation is a non-invasive technique. In this technique, stimulation is applied over the skin using surface electrodes. Today, I will mainly focus on this non-invasive transcutaneous spinal cord stimulation. Neurophysiological studies revealed that transcutaneous stimulation activates the same neural pathways as epidural stimulation does. Although the mechanisms are still unknown, stimulation likely modulates the excitability of spinal networks so that these networks and motor pools can become responsive to the weak descending drive after injury. As a consequence, stimulation can enable voluntary control of movement, even in people with clinically complete paralysis. The majority of the electrical neuromodulation studies focused on improving locomotor function. Within the past years, several groups have independently demonstrated restoration of volitional leg movement using lumbosacral epidural stimulation. In contrast to the automaticity of the central pattern generator for controlling locomotion, neuronal pathways of upper extremity motor control are more intricate due to neuromechanical complexity of the precise hand movements. Probably this is the reason that less number of studies focused on restoration of upper limb function by electrical spinal stimulation. However, it's very interesting that almost 30 years ago, a group of clinicians reported functional improvement in 78% of 112 tetraplegic patients who were treated with cervical epidural stimulation. The indication for cervical stimulation was pain in those cases. In this report, however, authors did not provide any detail for their stimulation strategy, so we don't know much about it. Additionally, and excitingly, positive results in autonomic functions such as blood pressure regulation, bowel, bladder, and sexual functions are noted in studies with epidural stimulation as well in the recent studies. How about transcutaneous stimulation? Studies with transcutaneous spinal stimulation show similar results on walking, hand and arm movements, and autonomic functions comparable to epidural stimulation. In the light of the recent developments and findings, let's look at the studies that use non-invasive spinal cord stimulation strategy closer. Currently, we continue recruiting participants for several studies in our lab. These studies target the restoration of upper and lower limb functions and also autonomic recovery. There are two upper limb studies right now. One of them is Uplift study. This is a multi-center trial to evaluate the safety and effectiveness of non-invasive stimulation. 14 centers and 4 countries are involved in this trial. This trial reached 65 participants now, which was the pre-planned target, and not enrolling new participants anymore. If the findings prove its safety and efficacy, it looks that the device can get the approval and it will likely be on the market soon. The other study in our lab is continuing to recruit participants now. The procedures are the same. However, study design is slightly different. In this address study, participants involve functional training and stimulation paired with training intervention blocks in a randomized order, and no intervention or washout period between 2 intervention blocks, and we have a longer follow-up period, up to 1 year. Overall goals of these studies are to determine functional improvement resulting from cervical transcutaneous stimulation during application of stimulation. And also, we aim to quantify long-term benefits that may persist beyond the stimulation. This slide shows the study design of the upper limb study that we completed and published the results. In this study, we conducted a prospective open-label 2 intervention arm study. Intervention arms consist of intensive upper limb training and stimulation plus training. All participants involved in training-only sessions in the first month, followed by Stim Plus training with the same schedule and with the same training protocol in the second month. And the treatment blocks, both blocks, repeated alternatively 1 more time. The reason for this alternation sequence of treatment arms was we wanted to understand more clearly whether the stimulation is contributing to the observed improvements or the improvements simply accumulating over time. In order to document the long-term persistence of functional gains without further treatment, we followed the participants for 3 months. Here is a brief list of inclusion and exclusion criteria of our ongoing actively recruiting study. People with spinal cord injuries between 21 and 70 years old are eligible. We include participants who are in chronic stage of tetraplegia, I mean, at least 1 year post-injury is required. We enroll individuals with AGA impairment scale C and D category injury. Let's recall together what the AGA impairment scale is. AGA A is complete injury, as you all know, means that there is no complete loss. It means that there's complete loss of motor and sensory function, including all segments, including several segments. AGA B is motor complete, but sensory incomplete injury. There is complete loss of motor function below the injury level, but some sensory function is preserved, including sacral segments. AGA C means that there are incomplete losses of both motor and sensory functions. However, more than 50% of the muscles below the injury level have less than 3 points muscle score. In other words, for example, individuals with AGA C category injury cannot raise their arms or legs off the bed. AGA D is also both motor and sensory incomplete. However, most of the muscles below the injury level have more than 3 points muscle strength. A 3-point muscle strength score means that the muscle can move the limb against the gravity. How about exclusion criteria? The most important items for exclusion are the existence of systemic diseases or health issues that may be a confounding factor, or that they may prevent completing the study. We also exclude participants who got botulinum toxin injection within 6 months, or have tendon or nerve transfer surgery, since these procedures has impact on functional measurements. For safety reasons, implanted active device in the body is another exclusion criteria. These are such as cardiac pacemaker, diaphragm pacemaker, baclofen pump, because electrical stimulation and these devices may disrupt each other's operation. All eligible participants based on these inclusion and exclusion criteria will get intensive task training. What is intensive task training? Intensive upper limb functional task training will be done 3 times per week and 2 hours per session. We use activity-based rehabilitation strategy. The training protocol consists of repetitive activities of gross upper limb movement, isolated finger movements, simple and complex pinch and grip performance. In each category, we designated 8 to 10 activities with various difficulty levels, and the participant performs 1 or 2 activities within each category in each training session. We choose activities according to the participant's ability, and we change or modify the tasks as function progress over time. We encourage typical movement patterns by guidance and giving feedback. And we limit compensatory movements. For example, we don't allow using tenodesis for grasping when possible. Next stage of the study protocol is training with transcutaneous stimulation. For delivering transcutaneous spinal cord stimulation, we use 2 different experimental devices from 2 different companies. Both have similar features. Electrical current waveform is either monophasic or biphasic. Pulse width is 1 millisecond. Burst frequency is 30 hertz. And the unique feature of this waveform is that it has a 10 kilohertz overlapping frequency that can selectively block the pain fibers in the skin, so that it is possible to increase the amplitude of the electrical stimulation that can reach the spinal networks over the skin without causing any discomfort or pain. We typically observe enhanced volitional control over the weak or paralyzed muscles between 40 and 90 milliamp stimulation intensities. We readjust the stimulation parameters as needed throughout the intervention phase of the study and throughout the session. For safety precautions, we closely monitor heart rate and blood pressure. We deliver stimulation up to 2 hours, 1-2 hours during each session. We use 2 small surface electrodes as active electrodes and 2 rectangular plates as reference electrodes. Active electrodes are placed midline on the skin of the neck, 1 above and 1 below the injury level. Reference electrodes are placed symmetrically over the iliac crests. Up to now, we did not observe any significant adverse events related to transcutaneous stimulation. To objectively measure and quantify the functional changes throughout the study, we use GRASP test. GRASP is the acronym of Graded Redefined Assessment of Strength, Sensation, and Prehension. It has 4 domains: strength, sensation, qualitative, and quantitative prehension. Manual muscle testing of 10 muscles in each site forms the strength score. Sensation is tested and scored by Swenstein monofilament test. Active positioning of 3 grasp and pinch movements are scored for qualitative prehension. And lastly, participants perform 6 different tasks for quantitative prehension domain. We repeat the test at baseline every 2 weeks during intervention phase, 1 with stimulation, 1 without stimulation, and after intervention phase, once a month, we repeat the test during the follow-up period. Secondary outcome measures, we use AGA examination and modified Ashworth scale for quantifying spasticity. Performance-based secondary outcome measurements include pinch and grip force measurements and spinal cord independence measure. We also document quality of life of the participants and other self-reported outcome measurements we use. These are bowel, bladder, related with bowel and bladder functions. This table summarizes the demographic and clinical characteristics of 7 participants who are completed our first upper limb study. Injury levels of these participants were C3 and C5. All of them were in chronic stage between 18 months and 12 years post-injury. 2 participants were AGA B, 2 were C, 3 of them were AGA D. All 3 participants with AGA D had central cord syndrome, and age range was between 28 and 62. These figures show the improvement curves of grasp strength score and pinch force from our first participant. Orange shaded area represents the stimulation plus training, and blue shaded area represents training alone period. Orange filled markers show the scores when stimulators active, and line width markers show the test results when stimulator is off. Grasp strength score was stable at the baseline and increased 37 points during stimulation combined with training. The increased strength was maintained during training alone and throughout 3 months of follow-up with no further treatment. His lateral pinch force improved in both the right and the left hands during first 4 weeks stimulation combined with training. Increasing pinch force was 2 to 7-fold in the presence of stimulation for the right and left sides. Training alone resulted in no further improvement, but all gains were maintained during the 3 months follow-up. Actually, he improved in every single motor function we measured. Next slide is a video clip that shows how the stimulation affects functional movements. So you will see the water pouring activity as a part of quantitative prehension subscore of grasp test. At baseline, before we start stimulation, the participant was unable to grasp the water bottle. But after 4 weeks stimulation, when stimulation was active, he was able to grasp and position the bottle. And at the end of 5th week with stimulation, he successfully completed water pouring task as his power grip and coordination improved. Now I will talk about the results from our 2 participants who had motor complete, AGA B category injuries. These figures illustrate or show that transcutaneous spinal cord stimulation paired with intensive training enabled these 2 paralyzed participants to regain movement and pinch force. The participant number 2 had no active movement distal to the wrists at baseline, and this situation did not change throughout the training alone phase. 2 weeks after we started stimulation, he regained volitional movement of his fingers and the thumb, that enabled him to produce measurable, small but measurable pinch force for the first time since injury. During the second 4 week of stimulation treatment, pinch force nearly doubled again in both hands. These gains were mostly maintained for 6 months of follow-up without further treatment. Although there was a slight downward trend toward the end of the follow-up, his function was not below that measured during the final phase of the training alone. Our third participant began the study 3.5 years after his C5 level AGA B category injury. His improvement in pinch force was similar to the second participant and also mostly sustained during follow-up period. For participants with incomplete injuries, the effect of stimulation started very quickly in most cases. We observed a very dramatic improvement of hand function as soon as we turned on the stimulator. This video shows the rapid response to the stimulation. Participant 4 had C5 level AGS-C category injury 12 years prior to beginning the study. He was not using his right upper limb for any daily activities. During training alone, function of his right hand did not improve. But on the first day of stimulation, however, he was able to pick up and release the ping pong ball easily. All participants improved in primary outcome measure, which is grasp test. Here are the cumulative improvements in grasp strength and prehension. The mean increase in strength of 10 muscles was 4 points by training alone. Stimulation paired with training resulted in additional 10-point increase, and the difference between training alone and stimulation plus training was statistically significant. Similarly, all participants improved significantly in their grasp prehension scores at the end of stimulation phase compared to training alone. Let's continue with the cumulative improvements in pinch and grip forces. Including participants with motor complete injuries, transcutaneous stimulation resulted in notable increases in pinch force. The increase was up to 4.8-fold compared to baseline. Grip force production also improved in participants with incomplete injuries. However, 2 participants with AGA-B injuries, motor complete injuries, were not able to generate measurable grip force at the end of the treatment. But here, I would like to emphasize that we did not allow participants to use tenodesis when we were measuring pinch and grip forces in order to document pure volitional motor control. As I summarized in the last 2 slides, the magnitude of functional restoration resulted from transcutaneous stimulation paired with training was really impressive. In the next video, I would like to show the functional restoration was not only immediate and remarkable, but it was also progressive and long-lasting. This is our 4th participant. On the second day of stimulation, he was not able to pinch 0.5-inch diameter marbles before we start the stimulator, before the stimulator turned on. However, after a few minutes of stimulation, after we started stimulation, he was successful to pick up the size of an object for the first time since injury. The audio captures his reaction to his rapid improvement.
Wow. Oops, I'll slow down a little bit. I'm acting like I'm a pro at this now. I'm just holding it and open it. Wow.
Helping, yes.
Oh,
this
man.
is 45. Let's go with this one if you can
Oh,
tolerate.
God. This is worth any kind of pain. This is amazing.
That is really amazing.
Wow. Like the other ones, like if I can get them, I'm like, they're just barely slipping out of my fingers. I can barely do it, but that's like a pinch.
So,
That was really cool.
Yes.
It's even crushing. Wow, that is really, wow.
His speech performance continued to improve, and he could pick up small beats by the end of the stimulation treatment, and even after 3 months of follow-up without treatment. Our findings demonstrated that non-invasive stimulation combined with training has augmentative effects on functional restoration during stimulation. But maybe more important than that, these improvements were durable. Functional gains were persistent during follow-up. Final scores were always greater than the scores that were measured after training alone phase of the study. As you can see in these graphs, increase in outcome measures by stimulation is clearly greater than training alone and persistent after stimulation. In other words, our results suggest that transcutaneous stimulation combined with intensive upper limb training is superior to training alone to restore motor function in patients with chronic spinal cord injury. Another beneficial effect of stimulation we observed was spasticity reduction. Spasticity severely interferes with residual motor function, and we know that it complicates performing activities of daily living. After several sessions of transcutaneous stimulation, we observed attenuation of high muscle tone in the upper limbs of our participants who had problems with the spasticity. It was really significant. The spasticity reduction was significant. And this video shows this effect. High muscle tone in the finger flexors made it impossible to open this participant hand, her hand to grasp the objects. This is the baseline. And the training alone sessions did not reduce the muscle tone. Now training alone, and he was still unable to grasp 1-inch wooden blocks at the end of day 12 with training alone. And starting from the first week of stimulation, the participant experienced gradual reduction of spasticity that allowed her to grasp and transport 1-inch blocks. Several days later, she could also grasp and release these blocks with much greater precision. And additional stimulation this is day 18. Additional stimulation enabled her to open her fingers and the thumb a greater distance to grasp 3-inch wooden pegs. The only thing I need to mention here, spasticity reduction was not long-lasting. After we stopped stimulation in 2-3 weeks, it gradually increased to the baseline levels. Outside of standardized tests and measures, the participants experienced other improvements as well. These include improvement control of volitional voiding, decrease in residual urine volume, and better thermoregulation. Our fourth participant reported that he started sweating below the injury level for the first time after 12 years of injury. This participant was also suffering from bradycardia, which made him feel dizzy and close to fainting early in the day. Beginning of the first week of stimulation, his heart rate gradually improved to normal 60-65 beats per minute, which was maintained throughout the follow-up period. Other improvements that we observed or reported by the participants were improvement of sensation, core stability, better balance, and increased sleep quality due to reduced nighttime spasms. Functional recovery is not only facilitated routine activities of daily living, but also allowed some of our participants to resume their hobbies. This participant was able to return to oil painting 5 years after her injury. The next video will show another exciting outcome of treatment with transcutaneous spinal stimulation. This participant was playing guitar before his injury. He told that after a few years of injury, he tried several times to play guitar, but each time he failed and felt frustrated. After we started stimulation, the rapid recovery of fine motor control of the fingers encouraged him to resume his hobby.
I focus and work at it for an hour, you know, it's like we can strum it.
Right.
And we can get that movement going. It's like we can't do it right now. So I'll just sit there for like a half hour and just like pulling it down.
That's why that particular movement's gotten
That.
so much better.
Just do it over and over and over until it starts to get a little better. Yeah. And that's how we even got here at all. It's like I just would do this, like just over and over until I could like, get it. It started like I couldn't even make the sounds. I couldn't push it down hard enough. And start to get it, and I started to do other ones, and pretty soon the chords start to come together. And I started to be able to play them on the neck, which that's like all those fingers like working together.
And this is at follow-up, at 6 months follow-up. No stimulation. His joy of playing guitar is really rewarding to watch. To conclude, we combine two critical components of neuroplasticity to promote recovery of upper limb function. These are electrical neuromodulation of the cervical spine and use-dependent rehabilitation therapy. Our results show that transcutaneous spinal stimulation improves upper extremity function in both complete and incomplete tetraplegics. It enables volitional motor control in completely paralyzed hand muscles. And the discovery of long-term recovery of the hand and arm function without further stimulation provides strong evidence of neuroplasticity. These findings also provide significant information about its potential to improve autonomic dysfunction. Another beneficial effect, rapid improvement in function, motivates the participants to engage therapeutic exercises. And another important point of the study is that benefits are similar to epidural stimulation with significant advantage of not requiring surgery. Now, I would like to talk about our transcutaneous spinal stimulation for standing and walking study, and also for autonomic functions. 2 participants are completed this study so far. The study is suspended for a while because of the pandemic. However, we will restart soon. The results of this study is just recently published in Physical Therapy and Rehabilitation Journal. In this study, we are stimulating the spinal cord at multiple points of the spinal cord, 2 from cervical level and 2 from low back. Participants get overground walking and body weight supported treadmill training 3 times per week for 4 months. Training plus paired with transcutaneous spinal cord stimulation. Inclusion criteria are similar to upper limb study, age between 20 and 70 years, chronic incomplete injuries above D12, and stable medical condition. These are our inclusion criteria, roughly. Among exclusion criteria, there is severe osteoporosis. To avoid fracture risk, bone mineral density T-score measured by DEXA should not be below minus 3.5 for inclusion. Another exclusion criteria is orthopedic surgery in lower extremities that may be a confounding factor for interpretation of the results. These are such as tendon transfer, tendon or muscle lengthening for spasticity management, arthrodesis, etc. We also cannot enroll participants who are taller than 80-inch or body weight is more than 350 pounds due to the limitation of the body weight support treadmill. The results obtained from 2 participants who completed the study are really impressive. This figure shows the results of 6-minute walk test. Blue shaded area shows walking distance during training alone, and yellow shaded area shows improvement of walking distance when training paired with stimulation. Walking distance increased threefold more after 2 months transcutaneous spinal cord stimulation paired with training compared to training alone. Both participants improved balance ability measured by Berg balance scale and increased their ability to engage in daily home exercises. We did gait analysis, which demonstrated increased step length for each individual. Both participants experienced improved sensation and bowel function. And one of the participants, eliminated the need for intermittent catheterization after the stimulation phase of the study. As a conclusion, our results show that transcutaneous spinal cord stimulation is a highly promising intervention for both upper and lower limb functional restoration and also for autonomic improvement. Studies up to now reported similar results with transcutaneous and epidural spine stimulation. However, both techniques has advantages and disadvantages, of course. Transcutaneous stimulation is non-invasive, easy to apply over the skin, has the potential for being widely accessible due to its non-invasive nature. On the other hand, epidural spinal cord stimulation requires surgery that can cause surgery-related complications, such as infections, requires battery replacement, and it's expensive. However, epidural stimulation with multiple electrode arrays may offer a higher degree of fine-tuning to activate specific motor pulse when we compare to service electrodes that we use in transcutaneous stimulation. Each one of them may be a better option for different people who has different clinical features after spinal cord injury in terms of level of injury, severity of injury, and also functional goals and preferences of the people are different. So one of them is not superior to the other. It should be considered case by case. So what is next? Still, there are many unknowns. The exact mechanism of action remains to be determined. To demystify the mechanism will help to improve the outcomes. We need to work on the optimal stimulation parameters. We don't know very well yet. For example, we will start a new study to understand closed loop stimulation, the effect of closed loop stimulation. Closed loop means start and stop of stimulation will be triggered by the movement instead of continuous stimulation during the sessions. The reason is that preclinical studies suggest that closed loop stimulation may enhance neuroplasticity better. We will also work on optimal stimulation parameters that reduce the spasticity for longer periods, not only when the stimulation is ongoing, but after we stop stimulation, we would like to find out optimal stimulation parameters that are beneficial for spasticity reduction. It looks that the magnitude and the rate of the improvements are not the same for every individual with spinal cord injury. given that outcomes of spinal cord injury is quite heterogeneous, we need to identify who can benefit from this treatment, who are responders, who are high responders, who are maybe not responders. It may not be for everyone. Studies showed the efficacy of non-invasive stimulation in selected small groups. So future studies with larger sample sizes are needed for investigating the effectiveness of the treatment under real-world conditions. Also, we need to test the use and the effectiveness of transcutaneous spinal cord stimulation at home or work environment during routine daily activities. And device companies are working on this and developing more compact devices. Okay, here are several links to our studies on various websites that you may be interested in. You can visit our lab website, or you may email me for more information anytime. Here are some more links to media coverage and videos you may want to look at. And this is the end of my presentation. I would like to acknowledge the support we receive for these studies. First of all, it's a privilege for me to be a member of Restorative Technologies Laboratory and working with Dr. Chad Moritz. I would like to thank to our sponsors who support clinical and preclinical research projects in our lab. And most importantly, I would like to thank to our study participants and their families for their motivation and dedication that made these studies possible. And finally, thank you all for listening to me today.
Thank you so much. That was so interesting, and have several questions. So I'm going to kind of do them in order, even though they may be a little bit out of order because it's easier for me to keep track.
Sure.
So I think one of the first questions that came up was you had presented early on about the fact that some of this work had been done 30 years ago, and yet nothing has been really moved into kind of clinical availability. Why do you think that is? Why hasn't it moved more quickly, or why isn't it ready for kind of home, that somebody could just get this from their physical therapist or their doctor?
The most important point here is the technical development. So today we have better technical opportunities in terms of the devices we use, and surgery techniques, strategies are also developed. So 30 years ago, probably these patients got limited arrays, limited electrode arrays, and they had high complication rates. So they needed to stop or reinstall, get the devices out of the body. That's why I believe that we needed to wait 30 years to start this kind of treatment again.
Yeah, no, it makes sense. I think this is, it's so exciting, and yet I think you raise these issues of what makes it complicated. Like, we don't know yet. So far, it sounds like you have not had any negative side effects from this so far. Mm-hmm. But you're not trying to push the envelope of what would be like you're not trying to get people to the negative point on it either.
Yeah.
Yeah. So tell me, one of the first participants had a little bit different protocol with kind of a shorter second follow-up. Was there a reason that, was he not tolerating, or was that just because it was the first participant and you guys hadn't finalized your protocol, which was my personal guess?
Thank you so much for this question. I did not explain it at the beginning. When we enrolled our first participant, we received the device for a short time from UCLA. We borrowed it. So we started with this stimulation plus training for the first 4 weeks. And then we sent back the device to them for their use. And we continued with the participant with training only sessions. But we were so curious if we start stimulation again, if the improvements will be boosted again, because there was a really quick response when we started stimulation, but at the end of 4 weeks, it reached a plateau, and during the training alone, the functions did not improve. So we requested the device again and got the stimulator for another 1 week, which boosted the improvements one more time. But starting from the second participant, we had our own device, and we followed the regular protocol for the rest of the participants. That's why. So there was not it was not a tolerance problem or any other problem.
Perfect. It was just the beginning of science when you're having to kind of make things happen as they go. Yes. So I think there's a couple questions kind of about that, like this process of, we have these really cool findings, relatively small group right now, but kind of from this point, what is the pathway to, like, what other studies have to happen before this could end up getting FDA approval and be available for anyone with spinal cord injury to get in, from their physician or physical therapist or other provider?
For the upper limb, restoration of upper limb functions, I believe that the UPLIFT study that I mentioned, multi-center study, 14 centers and 4 countries involved in the study, 65 participants enrolled already, but the results are not analyzed yet. I believe that if the results are as good as the small studies, as good as expected, the FDA approval will come quickly in maybe in 1-2 years. But at the beginning, it will be the approval will allow to use the device in the clinics, in the PT clinics, OT clinics. And I also mentioned that we are working on home use. A new study will start soon for the safety and efficacy of the home use of the devices. We don't know how it will go when you are doing the routine daily activities. Will it be useful or not? How long should be used? Should it be continuous, let's say 12 hours a day, or should we use it limited times? We will explore this. And after we get enough data showing the safety and effectiveness of home use, then probably individuals will be able to get the device for their own use at home.
That's perfect. So it's in process. We're closer to having it be available, and then still some more research needs to be done to get it into the home. But that's great. Nice. I'm curious about, you had posted the funders, and they are all, highly respected research agencies. And is there stimulator makers, producers who are involved at all in this work, because they stand to actually gain from this, right? So has there been any work with some of the stimulator makers, or is there any kind of joint projects to make it easier to use or more accessible for people to think about for home use?
Maybe I did not understand the question correctly. So would you please repeat it?
Yeah, the people who make the stimulator itself, those producers, did they ever fund this research, or are they involved in the funding of this research?
Yeah, actually the UPLIFT study, the multi-center study, is funded by the developer, one of the companies that produced that device.
Yeah. So they are committed to helping with the funding?
They sponsored the whole study with this uplift study, but the other studies are investigator-started studies. So there is no conflict of interest, I believe.
Right. That's great. Do you, like, what is the research that, or do you know what research is going to be needed to have insurance companies actually pay for this? Like, what are the results, or what are the kinds of things that, have you been thinking about that? Like, how would this get funded, you know, out in the real world?
For sure, large sample size studies are needed for this. In the real world environment. In the clinics, multi-center studies are important here. I don't know how many participants are needed for such a proof of evidence and safety, but I think several more years are needed to prove the efficacy to convince the insurance companies.
Yeah, and I would also guess that some of it is going to not just be functional improvement, but I think some of the autonomic, like, you know, prevention of other complications might also help as well. So it'll be interesting to see that data. The other one other question that came up about kind of your you know, the sample, is there, well, there's a couple of them. One is that have you thought, or is there any research ongoing for people who are earlier after spinal cord injury? So within that first early period where they're having natural recovery often, is there work being done to see if there might be some additional benefit in that population?
I believe so. Starting the stimulation earlier in the first year after the acute phase, during the subacute phase, may be really beneficial to improvement, the natural neurological improvement, because we know that the first year is important for natural restoration of function. Everybody gains something during the first year, and most of the people reach a plateau at the end of 1 year. Now we know that in the chronic stage, this therapy is working to improve function, but although we do not know how it will work during the subacute phase, I feel that, my gut feeling that it will be helpful in subacute phase. But right now, there is no such a study, there is no data about it.
Right. No, that'll be very good to see that data coming out. Another question on sample is that what was the decision about not to include people over 70? Was there some specific reason for limiting in the current study? Because, you know, people who are otherwise healthy, who are still working on improving, is there, you know, kind of what were the reasoning around that age limit?
So this is the early stage of these studies. And we know that neuroplasticity may be affected by age. That is why we limited at 70, but it doesn't mean that people over 70 years old will not benefit for this. But more studies, larger sample sizes, we will include more people in all ages, even pediatric groups. So we will learn more, and we will understand better who can benefit from this treatment.
Yes.
The same thing for AGA A's, B's, C's, and D's. We need more studies to understand better. We just now, we limited to enroll participants who have AGA C's and D's, because you cannot do everything at the same time. And I understand, we understand from our previous study that longer stimulation periods may be needed to obtain the improvements in more severe injuries. Absolutely, we should do this. But for now, we need to limit.
think that this is a common complaint and complexity when you're doing research, is that the research process takes time, and to do it well, you need to move through and get funding and, you know, collect the data and analyze the data and move on to the next study, and things build on each other. But I'm glad to hear you guys are thinking about it and that you're working towards that. But again, I think this is the complicated part, is everything takes more time than we love it to. We'd like it to go faster. But yeah. Well, another question came up of, are most of the pad placements peripheral, so like on the extremities, or really are they right along the spinal cord, or is it both? And then any difference in efficacy about, like, how did you all even decide where the placement needed to go, and does it change depending on what you're doing?
From the preclinical studies, it is said that it's the best to put one electrode above the injury level, one below the injury level on the midline of the spinal cord over the skin. However, spinal cord injury is not symmetrical. So if midline placements of the electrodes did not work, we tried several other things. We moved the electrodes closer, farther to the right side, to the left side. Even we put the reference electrodes to the shoulders to make the electric stimulation more strong over the spinal cord. So as I told, we don't know the optimal parameters yet. So we are still trying, and each session we are trying to find the sweet point that helps the movement for the participant. And also this is different for different activities. For example, for strengthening exercises, higher intensities may work better. For fine motor skills, lower intensities work better for sometimes, but this is not a rule. We need to, still we are testing in each section with each participant which parameters work better for this participant.
Mm-hmm. Yeah, I think that's where it gets complicated, right? Is that and how much of the individual difference is there? So some of the general things. So I think your slide that you're talking about, really trying to understand and demystify, like, what is the process, will help us understand more about kind of what's being stimulated with higher, lower, larger, smaller. And I think you know, whether or not people are doing some of the kind of FES kind of stimulation versus this spinal cord, like where is the action happening, can also be different as well, right?
Yes.
Yeah. Let me see. Let me look through my questions really quick. Oh, so I mentioned this, but I'm curious from the research that you've done so far, like from the point at which you got funding to start a study, like, so the first, you know, group of participants that you did, those, I think there was 7 that you had talked about, from the point at which that you got funding to start that study to publishing the first paper, what amount of time did that take? 4 years. Yeah. Okay. I think it's important for people to hear that, right? Because we talk about it in generalities, but I think that it's, you know, if you think about each participant taking several months to go through the process, and then they were only one at a time, correct? You brought in
Yes,
people.
Absolutely. And 2 hours with each participant for each session. So we did, for the first 7 participants 512 sessions, which means 1,024 hours total.
Yeah.
Which is a huge commitment from our participants' side. We did it, we love to do it, but it's also a huge commitment from the participants as well.
Yeah, absolutely. And I think that's so true of, you know, and people may be aware is that we have a podcast that we did with John, who people saw in the video. And so people can check that out on our podcast, but he talked about like the commitment and time that went into that. And so if people are interested in hearing about kind of his participation and what that was like for him, we have that podcast available as well. Another question that came in is, did you have any assessment or did people note any benefit with neuropathic pain or pain in general?
Interestingly, none of our participants until now did not have severe pain. Some of them had neuropathic pain, but they were completely under control with simple medications or small doses of medication. So during the treatment with transcutaneous stimulation, their neuropathic pain did not change, did not increase, did not decrease. We did not observe any change in the pain course. And as I told, we were lucky that our participants did not have severe pain. But this is an interesting topic because the basics of spinal cord stimulation is pain. This may be helpful, but I don't have the data. I don't know.
Right. Well, I was going to say that's probably good that we don't have a lot of participants that are reporting that, but it would be interesting to again see in other studies maybe to even focus on that to see if it can help with function and with pain. Thank you, Dr. Inanici. I so appreciate you spending the time with us tonight. Thank you so much, everyone, and have a good evening.
Thank you. Thank you, Dr. Hoffman.
Yes, wonderful to have you here. Thanks so much. It was great.